So we now begin discussion of cardiovascular 2, lecture 28, part 1. We will focus primarily on the development of the venous system. So this first illustration shows us the adult structures with the heart, the right side blue for deoxygenated blood, the left side red for oxygenated blood. We know that the venous drainage systemically is from the left brachiocephalic for the left upper extremity and the head and neck region, and the right brachiocephalic from the right head and neck and the right upper extremity. Those two brachiocephalics fuse or join to form the superior vena cava that drains into the right atrium. There's also a major venous drainage of the heart into the right atrium. And then the third structure draining into the right atrium, of course, is the inferior vena cava that comes through the liver. So the hepatic veins will drain directly into the inferior vena cava, and then the abdominal vena cava will be formed by the junction of the common iliac veins, of course, draining the lower extremity. So we'll follow the development of structures leading to this adult orientation. So in this figure, 14.2, we're looking at the embryonic cardiovascular system about 26 days, and it shows the vessels on the left side only. So the umbilical vein, and again, they're showing it in blue, but it's carrying oxygenated blood back to the embryo from the chorionic villi. So this blue should be red, and this red, the umbilical artery, of course, should be blue. But we'll just leave it as this blue venous and red arterial. We see the vitelline vein draining the yolk sac toward the embryonic heart, and we also see the cardinal venous system with an anterior cardinal vein and a posterior cardinal vein draining to the common cardinal vein into the venous end of the tube-like heart. We see all the segmental branches of the dorsal aorta and of the vitelline veins. So all these segmental vessels have formed very early on through mechanisms that we've described previously. So the vitelline veins are paired. They return the unoxygenated blood from the yolk sac. They run through the yolk stalk. They pass through the septum transversum. We know the liver develops within this in part. Enters the sinus venosus, the early atrium, become linked to the liver sinusoids through their association with the mesenchyme and the septum transversum, and of course the outgrowing liver bud, and it gives rise to the hepatic veins and the portal vein. The umbilical veins, they are paired. They return the oxygenated blood from the placenta. They run on each side of the developing liver. They enter the sinus venosus on the venous end of the heart. They eventually lose connection with the heart and empty into the liver. So all of the nutrients, as with the portal venous system, in the neonate and through adulthood, all the nutrients absorbed go through the liver first. So the nutrients coming from the placenta go through the liver first for processing before they will enter the venous return to the heart, systemic venous return to the heart. The right vein will degenerate and the left vein will persist. The venous shunt to avoid the liver, the ductus venosus, connects the left umbilical vein with the inferior vena cava. So there is a shunting that does occur. The common cardinal veins, as we saw, they're paired. They are lateral vessels which return unoxygenated blood from the embryo to the embryonic heart. The anterior branches drain the cranial parts of the embryo, and the posterior obviously drain the caudal portion. The anterior and posterior join at the common cardinal veins to enter the sinus venosus. So here, figure 14.5, we're looking at a dorsal view of the developing heart. And so during the fourth week, about 24 days, we are seeing the primordial atrium and the venous sinuses, the horns, the left horn of the venous sinus and the right horn receiving the common cardinal venous drainage, anterior and posterior draining into that or joining to form that. And then the the umbilical and the vitelline veins are shown also draining into the horns of the sinus venosus. So there's an opening, we're just kind of looking through a window, an opening of the sinus venosus into the primordial atrium here for venous return into the primordial atrium. Now, we are looking at 7 weeks showing the enlarged right horn of the sinus venosus and the venous circulation to the liver, and the organs are not drawn to scale. And then in panel C, we'll see 8 weeks indicating the adult derivatives of the cardinal veins. So now we see the enlarged right horn of the sinus venosus receiving basically the inferior vena cava, and it has the left horn of the sinus venosus receiving the left common cardinal vein. This is going to end up providing venous drainage of the heart, the anterior and posterior cardinal veins, and we see the anastomosis between the anterior cardinal veins. So it's going to let us give up some of this venous flow back here. We see the anterior cardinal vein on the right, obviously is going to be a primary systemic venous drainage toward the atrium. Within the liver, we see the intrahepatic inferior vena cava. The 2 hepatic veins drain into that. And we see the portal venous system developing in this area here. The vitelline veins around the duodenum will coalesce to form the hepatic venous drainage system. And also farther from here, we'll have the superior mesenteric vein, and the inferior mesenteric vein, and the splenic vein all coming together to contribute to this venous flow, the hepatic portal venous flow. Again, draining substances, draining blood from the capillary beds of the intestines after absorption and bringing it to the liver first before it passes through the liver sinusoids and then through the hepatic venous system into the systemic venous drainage, the inferior vena cava, and then back to the heart. We see blood flow returning from the placenta, should be red or kind of off reddish, and it is bringing the oxygenated blood and nutrient-rich blood into the liver, and then there is a ductus venosus shunt that takes it right to the inferior vena cava. And then finally we see here the posterior cardinal vein is gone. The remnant of the left horn and the common cardinal vein are going to form the coronary sinus, which is a large vein on the posterior surface aspect of the heart between the atria and the ventricles. And then an oblique vein runs from there around the left atrium to drain the main veins of the side and the front of the heart. Then on the right side, we're seeing the right atrium developing here, the inferior vena cava coming from the hepatic portion up into the thorax, and then it's only a short length above the diaphragm, goes straight into the right atrium. And then we see on the right side the root of the azygous vein and a brachiocephalic vein, the right one, and the left, so that anastomosis between the anterior cardinal veins becomes the right brachiocephalic vein, and we see the left brachiocephalic vein here. I did get my left and right reversed on that, my apologies. I'm thinking the left brachiocephalic vein is longer than the right brachiocephalic vein. But anyway, the right and the left brachiocephalic veins join to form the superior vena cava that drains into the right atrium. And we just discussed the formation of the inferior vena cava within the liver. So which is the correct sequence of normal blood flow between the mother and the fetus? So from the umbilical vein to the fetal heart and then out through the dorsal aorta to be distributed. So that shunt within the liver is very important, obviously. So continuing with the veins then, the common cardinal vein is shown here, and is discussed here, excuse me. They are paired. They're lateral vessels that return unoxygenated blood from the embryo to the embryonic heart. So the venous shunt develops between the right and left anterior cardinal veins and becomes the left brachiocephalic vein, as I had corrected myself. The superior vena cava, or the famous SVC, is derived from the right anterior cardinal vein and the right common cardinal vein, as we had seen. So most of the posterior cardinal veins degenerate, but some persist as the azygous vein, draining the posterior thorax and the intercostal venous drainage system from the posterior and lateral aspects. And the common iliac veins remain as well, farther caudally. So we can follow that development through a series of slides here. We are starting here with figure 14.4. This gets a little bit confusing, but what we're focusing on are the anterior and posterior cardinal veins, mostly posterior cardinal veins, and we see that they come together, the right and the left come together through a common drainage of the common cardinal veins on each side into the sinus venosus that we talked about. And then caudally, of course, there's an iliac venous anastomosis, and this is where the common iliac veins are going to develop. As we said, part of the posterior cardinal veins persist as the iliac venous drainage system. At this stage, let's see, we are at 6 weeks, then we'll go to 7, then 8, and then to adult. So at 6 weeks, a subcardinal venous system develops kind of parallel to the posterior cardinal veins, with some anastomoses that are actually formed through the mesonephros. So remember, there's a lot of vascular development in the mesonephros, so they would all be here, and we just developed these anastomoses that go straight through. And there's a midline anastomoses connecting the left and the right sides. So we're going to follow posterior cardinal vein, subcardinal vein, and then a new one, the supracardinal vein, that pops up. And we begin to see some interesting changes. The anastomoses with the subcardinal venous system will persist in some areas and disappear in other areas. The connections we see disappearing here, and excuse me, the posterior cardinal vein now has a connection with the supracardinal vein on each side. There's also this midline, the subcardinal anastomosis that we had mentioned. So a lot of these structures are all going to come together and fuse and contribute to the formation of the inferior vena cava, showing the renal segment of the inferior vena cava, so right near the kidneys, coming from the supracardinal anastomosis. And we see the other, the subcardinal anastomosis here, and the prerenal segment of the inferior vena cava is formed from that. And then we see the intrahepatic segment that we talked about before. And then we're seeing the renal veins draining in, and the stem of the internal spermatic veins here. So as the gonads had developed in this area, we see the internal spermatic vein here. So the organs developing in these areas will pick up their vascular supply and obviously sustain it is the point. So the posterior cardinal veins disappear for the most part. The posterior anastomosis persists as the iliac venous anastomosis. And we see the external iliac vein and the hypogastric veins draining into there. So obviously we're seeing the inferior vena cava forming along here, and then the posterior cardinal veins up near the common cardinal veins are going to sustain a linkage with the supracardinal vein. Some of that will disappear on the left side, so now they've switched it around on us again. So we see that long left brachiocephalic vein and the left subclavian vein. So we lose the posterior cardinal vein with its anastomosis to the supracardinal vein there. But on the right-hand side, we see the right brachiocephalic vein with the internal jugular vein and the external jugular vein and the subclavian vein, the right subclavian vein draining into it. And then the two brachiocephalics join to form the superior vena cava. And we find one other vessel draining into the superior vena cava. This is the azygos vein that will drain the intercostal spaces, and the supracardinal veins form both the left and the right azygos veins and sustain their connection with the right posterior cardinal to drain into the as the hemiazygos veins, the supracardinals, the left over there and the right here, and then they sustain their connection with the right posterior cardinal vein to form the azygos vein. So two hemiazygos drain into the, and that's even incorrect. Sorry, the right one is the azygos, and the hemiazygos is on the left, and it drains over into the azygos veins on the right. Well, if that didn't confuse you, let's continue. We see the clustering here. And if you're going to become an expert in this, it's going to take a little more than what we're doing, right? So we're trying to familiarize ourselves with the miracles of the development of the vascular system. So we see the right suprarenal vein draining into that pre-renal portion of the IVC, and then the renal portion of the IVC receiving the right renal vein. The left renal vein is longer than the right renal vein, and it crosses anterior to the aorta, abdominal aorta that would be in this area here. So it is longer, and the left suprarenal vein, the left internal spermatic or ovarian vein drain directly into the left renal vein. The right spermatic vein or ovarian vein drain directly into the inferior vena cava, the renal portion of the inferior vena cava here. Well, let's proceed. So which veins open into the sinus venosus? The vitelline or omphalomesenteric vein, the umbilical vein, and the common cardinal vein at both sides. What are the derivatives of the left and the right horn of the sinus venosus? So the left one we saw becomes the oblique vein of the left atrium and contributes to that coronary sinus. And the right becomes the smooth-walled portion of the right atrium. So which veins can be first distinguished in the embryo? There are three pairs of major veins that we've started with: the vitelline or omphalomesenteric veins, the umbilical veins, and the cardinal veins. From which veins does the portal vein develop, and how? So the vitelline veins, as we said, contribute to the formation of the hepatic portal system. So before entering the sinus venosus, the vitelline veins form a plexus around the duodenum. They pass through the septum transversum, within which the liver is forming. The liver cords grow into the septum, interrupt the course of the veins, and an extensive vascular network of hepatic sinusoids is formed. So the hepatic portal venous system, as we have seen already when we talked about the development of the liver, drain into the venous sinusoids. There are sinusoids in between the hepatocytes. The anastomosing network around the duodenum develops ultimately into that single vessel, the hepatic portal vein. So what is the ductus venosus, and what role does it play in the embryonic circulation? So communication between the formal left umbilical vein and the right hepatocardiac channel is from what the ductus venosus forms. And the ductus venosus bypasses the sinusoidal plexus of the liver. So the umbilical venous drainage of the placenta, part of it is shunted through the liver, passes through the liver, but most of it obviously is shunted through this ductus venosus directly to the heart, because we want to get oxygenated blood circulating through the embryo and fetus as quickly as possible. but we want some of it to go to the liver, so the liver is receiving nutrient-rich blood and dealing with it in a developmental fashion such that it'll be ready at birth once absorption from the gastrointestinal system occurs naturally. So the vitelline arteries, they are paired. They supply the yolk sac, the allantois, and the chorion. They give rise to the gut arteries, the celiac, superior, and inferior mesenteric. The umbilical arteries, as we said, are paired. They carry the poorly oxygenated blood from the fetus to the placenta. Most degenerate, but they will give rise to the internal iliac arteries, as we said, and the part that degenerates becomes obliterated, and it is still within the anterior body wall going up to the umbilicus. So there are 3 ligaments in this area, right and left. Well, there's one median right in the middle, the urachus, and then there's a middle, which is or medial, which is the obliterated umbilical arteries. Then there is a lateral ligament as well, and that's formed by another structure that we won't bother with for now. We've got enough information. So the cardinal artery system, as we saw, they are the paired dorsal aorta. The aortic arches, of course, develop in weeks 4 and 5 to supply the developing pharyngeal arches at the rostral end of the embryo. They arise from the aortic sac and terminate in the dorsal aorta, as we noted. During weeks 6 to 8, they become the carotid, the subclavian, and the pulmonary arteries. So here in figure 1438, we see the first illustration of the arches, and we will present the development of the arterial system starting with this slide in the next lecture.